I just wanted to go over some newer things that we're doing. I think everybody here is pretty well versed in POTS and the physiology and things. And so the questions that I'm going to try and answer are, could POTS have an autoimmune basis? Also, could there be what's called an autoinflammatory component? And also, could there be an overlap between neurocardiogenic syncope and POTS or vasovagal syncope? And so we've been publishing a series of things I wanted to share with you. So what is an autoimmune disorder? Just sort of going over it. I didn't know who my audience exactly was going to be. Antibodies are these protein complexes that identify areas that are foreign and then sort of become targets for T cells and B cells to destroy. They bind to areas called antigens. And again, having had a background mainly in electrophysiology, this was sort of a new field for me. And so the antibodies themselves, I think you've seen these pictures, they have several parts of them that bind. And again, they normally bind to foreign objects such as bacteria or viruses, and then are markers for immune cells or killer cells to come in and destroy that area. And unfortunately, what can happen, particularly increasingly in the modern world, is that these antibodies can bind to parts of us that are self instead of other, and then your own immune system can come and attack them. So why did we think that there was an autoimmune basis for POTS? Well, in 70% of the cases that we've seen, people will describe onset after some kind of febrile illness that's been presumed to be viral. There's a higher frequency of POTS with known autoimmune disorders. We see many people who have thyroiditis, who have Sjogren's syndrome, who have rheumatoid arthritis, who have a number of other autoimmune processes. And also, we've also seen that a group of POTS patients will later develop autoimmune processes, especially multiple sclerosis. So we felt that there was some kind of link there. And again, the group, again, I wasn't sure who I'd be talking to, but just to review, what happens in many people is there is an inability of the peripheral vasculature to maintain sufficient degrees of constriction during orthostatic stress, which allows excessive amounts of vascular pooling with a compensatory tachycardia and increase in myocardial contractility. This is from the work of Julian Stewart, who has been a pioneer in the field. And this just shows you a control subject and a patient with POTS showing a much higher heart rate and somewhat lower blood pressures. And also you can see the pooling effect with the development of acrocyanosis, and also some degree of swelling of the tissue is measured by plethysmography. And then they have a whole range of symptoms, which, as I've learned, are not unique so much to POTS, but rather are seen in many autoimmune disorders, where there's a generalized sense of malaise and feeling unwell that seem to occur in many, many patients. And this is from work done at the Mayo Clinic. One of the amazing things to me is how interconnected this is with other illnesses and other things. And I came across this quote from Da Vinci, which I think is applicable to these matters. So the idea that we could isolate antibodies to give credit where credit is due. Steve Verino did landmark pioneering research while at the Mayo Clinic and was the first one to identify autoantibodies to acetylcholine receptors that were in a somewhat different group of disorders, but autoimmune dysautonomias. And this is from a paper he published in the New England Journal in 2000, looking at thermoregulatory sweat testing in individuals and comparing it to the antibody titers that were seen there. And he demonstrated extremely convincing evidence that there could be an autoimmune pathology to some of these disorders. Later in 2014, Dr. Kim, who unfortunately passed away due to COVID, and his group at the University of Oklahoma did, again, landmark research demonstrating the presence of autoantibodies, principally to alpha-1 receptors in vascular tissue. and did this in about 14 patients that were published in 2004. I mean, 10 patients that were published in 2014. And again, this was a truly landmark study that I think he doesn't get the credit for he deserves. So just to go over where these are, there are adrenergic receptors throughout the body. The alpha-1 receptors are in the blood vessels, oftentimes in the skin. They also are heavily within the gastrointestinal tract. And alpha-2 receptors are in the brain. They also are in perisynaptic nerve areas and things. So these are extremely diffusely found throughout the body, not just in one particular place. And based on Dr. Kim's research, we suspected that there was a high density of alpha-1 receptors that could be part of the etiology of these. There have been a series of people who have been looking at the presence of autoantibodies in a variety of autonomic problems, and these include not only just POTS, but also idiopathic orthostatic hypotension, and also in diabetic patients as well. And so there's been a huge amount of research that has been coming out lately. One of the great contributors in the field is Dr. Arthur Fedorowski in Sweden. And this is somewhat of an overview of these studies that have come out to date. I've sort of recapped them here. And everybody's been using various technologies to be able to look at this, but we all have the same idea that there's some kind of autoimmune pathology going on. So there's been a progressive building of research in a number of different studies looking at, could we find these antibodies in different individuals? Now, there's also a feeling that there could be a muscarinic component, especially Dr. Verino's research at Dallas Southwestern has been showing that he feels that there is a muscarinic antibody that's present that also could play a role. So we decided to look at these, and we looked at 55 patients originally, and then we showed that 89% or close to 90% had extremely high levels of autoantibodies to alpha-1 receptors. And there were other ones too, but they were at a much smaller frequency. So the number was high enough that we were extremely intrigued by this as a potential pathology. We also incidentally found that in 50% of the people who were positive for alpha-1 autoantibodies, that they also had muscarinic M4 receptor antibody levels at very high levels. And we feel that this has a role in the pathophysiology, although it's unclear exactly what it is. The M4 receptors have not been well characterized in humans. So their role is somewhat of a mystery. However, M4 receptors are very densely found within the basal ganglia of the brain and help govern dopamine release. Now, interestingly, we also identified 7 patients where the levels of everything was elevated. And these tended to be very sick individuals. And it really sort of, I think, brings home the fact that we're dealing not just with one entity, but rather a number of different subgroups that could be present, with different people having different levels of antibodies present, not dissimilar to what some of the rheumatologic disorders have. So to summarize, in this study, we showed that 89% of patients had high levels of circulating alpha-1 adrenergic receptor antibodies. And then 50% of patients out of that group had elevations in the muscarinic M4 receptor antibodies. Now, we also thought that there could be another component. My research partner, Dr. Gunning, is an internationally known expert in platelet function, and there is a growing body of research that is demonstrating that the platelet may play an important role in the immune system. Indeed, platelets may be part of the first line of defense in the immune system. Dr. Gunning is an expert and co-discoverer of a condition called delta granule storage disease of platelets. It is a type of clotting disorder, which was originally thought to be relatively uncommon. However, as we began to look at our patients, many of them would complain of bleeding problems, extremely heavy menses, nosebleeds, easy bruising. And as part of our evaluation of these individuals, because it's one of the tests that are done at this institution, we would not only get the standard coagulation panels on them, but also would look for delta granule storage disease. And to our amazement, many of these patients would come back positive. So we wondered if there was some kind of association here. And when you look back through, you know, these in POTS patients, a number of the patients we saw would complain of symptoms that were suggestive of platelet dysfunction. And indeed, many of these people, as I said, had all kind of bleeding disorders. What we found is that almost 80% of patients had evidence of delta granule storage disease, as opposed to an expected incidence, and this was a case control study, of only about 5 to 10%. These are examples of normal platelet morphology with normal amounts of dense granules that you can see in these areas. So when we compared our patients with POTS who had a history of bleeding to match control subjects, we found this a huge difference in the frequency of this disorder, suggesting that it was acquired rather than a congenital thing, and suggesting it had some role in the pathogenesis of it. Now, again, I am sort of getting out of my level of expertise. I am fortunate enough to have an immunopathologist to work with. But the platelets have all of the known 10 toll-like receptors on. It appears to be an integral part of the innate immune system. We'll talk a little bit more on that in a moment. And it's thought to be one of the first lines of defense. I didn't know this, but it secretes a number of the inflammatory cytokines that are released during the innate immune response to infections. Now, most of us have kind of forgotten since medical school that there are two aspects of the immune system. There's one part called the innate immune system you were born with. The other is the adaptive immune system that you acquire over time. The innate immune system will use mast cells, macrophages, neutrophils, and a series of compounds that are called interleukins to be able to identify and be chemical signals that there's some kind of invader present. And the adaptive immune system is the one you're more used to thinking about, composed of T cells and B cells with antibodies that mediate the response. We suspected that there was an innate immune component that could be present in individuals and that could play a role in the pathophysiology. Oftentimes, the innate immune system is very nonspecific in nature, whereas the adaptive immune system is very specific in what it attacks. So we decided to ask the question, is there evidence of an innate immune involvement? So we took plasma from patients that were known to have POTS. We did this mainly this was during the height of the pandemic, and we could not draw any new samples, but we had a number of samples stored in the freezer from our initial study. So we said, well, let's look at these and see what the levels of different cytokines are. And we also reran the levels of autoantibody, of alpha-1 autoantibodies, as well as muscarinic antibodies, and we found the exact same things as we did in our initial study. But we also found a number of markers of interleukin and cytokine levels that were markedly elevated compared to normal ranges, to the established normal ranges that have been published. And again, suggesting that there is a innate immune response system going on, and an autoinflammatory response as well as an autoimmune response. Now, we took this further, and we had a number of samples frozen in the freezer. And because of the fact that because of the pandemic, we couldn't go out and get new samples. We had 35 samples left from one of the studies that Dr. Gunning had done that were control subjects for a platelet study. And we decided to use these to compare to 35 POTS patients that we had samples stored for. And we looked at it at 16 cytokines that were done. This was assayed by a company in Georgia that we've been working with, Ray Biotech. And again, what we found is a marked elevation in inflammatory cytokines compared to matched control subjects, indicating some kind of autoinflammatory response that has been very, very prominent. Now, we're sending for publication in the next week or so. But again, it shows there is a heavy inflammatory component going on, suggesting some kind of autoimmune process is going on in large numbers of these patients. Now, again, this has to be worked out in much larger scales. We're actually now, the university has allowed us to resume research, and we've gone back. We're initiating a study looking not only at POTS patients, but also at matched controls. So these are the conclusions we've come to so far. These are going to have to be confirmed by larger studies, which we have initiated. And hopefully, now that we're able to draw samples again, we'll be able to get back to being able to demonstrate this. We've also been seeing, as you've no doubt seen in the news, and Hopkins has a center for these individuals, a number of patients who have developed POTS-like symptoms or autonomic symptoms after suffering a COVID-19 infection. These are the long haul patients. There have been a number of reports about these. We have published one of them. And another arm of the study that we are doing is looking at post-COVID POTS patients to determine whether or not they possess the same autoantibodies and inflammatory markers as our regular post-viral POTS patients. And again, we've just enrolled our first several patients, so I can't give you much in the way of progress thus far, except that we're working on it. Now, another aspect of things which we've been looking at is whether or not there could be crossovers between these different autonomic conditions. So we got interested in this because some of the POTS patients would describe frequent episodes of syncope and near syncope, even though in the office they would demonstrate all the classical tachycardic responses. And during tilt table testing, you would see people who would suddenly become hypotensive and go into asystole, much the same as the neurocardiogenic syncope patients would. And we began to ask the question, are they doing this on the outside? And so to test this hypothesis, we wanted to monitor them long times. The idea of monitoring people, by the way, on the outside is credited to Dr. Norman Holter. You may not know that was a person. You just call it a Holter monitor. This was the original. I found that when I was doing some research for a paper, this was the original Holter monitor built in 1947, and it weighed 85 pounds. And that's a motorcycle battery up here to power it. But he was a genius and got it down to about and by 1964 to 2.8 pounds. What we've used are implantable monitors, and these are injected under the skin. These were the original ones. We were fortunately one of the first centers in the U.S. to implant these in the mid-90s. Every major pacing company now makes one of these, and they can provide long-term monitoring with the newer devices lasting up to 5 years. They're injected under the skin here. In women, we put them a little bit higher to be out of breast tissue. And this is what it looks like on an X-ray. And this is an example of what we've seen. So we had a group of POTS patients that had recurrent episodes of syncope and near syncope, even though in the office they did not, they displayed all the classical features of POTS and things like that. So we asked the question, could they be having periods of bradycardia or asystole? In our previous studies, we identified 3 factors that were predictive of individuals having periods of asystole or at least extreme bradycardia, and they were syncope without warning, convulsive activity witnessed by bystanders associated with it, or prolonged loss of consciousness that we defined as greater than 5 minutes. Recently, we've added a 4th, which is injury, bodily injury suffered during a syncopal event. So this is a young woman who had post-viral POTS, had classical symptoms and hemodynamic findings in the office, but again, was experiencing episodes of sudden loss of consciousness, that were associated with convulsive activity, and at the same time that lasted longer than 5 minutes. So this is her during an episode. She's just going along at a little bit higher rate than normal, and suddenly you can see that during her episode she slows down to fairly bradycardic levels, and then just goes into complete asystole, lasting 25 seconds or more on this episode alone. So based on this, we published a first paper. We looked at 39 patients that were clinically found to have postural tachycardia syndrome. And again, in these individuals, we demonstrated prolonged asystole or bradycardia, and we defined bradycardia as less than 30 beats a minute for this. In these individuals who had proven refractory to any other therapy, they underwent implantation. We used a pacer that has the capability of closed loop. Episodes were eliminated, not their other POTS symptoms. So this approach is only applied when we've documented without any doubt that they're having recurrent episodes of asystole associated with their syncope. And again, when we put the pacers in, it's eliminated the syncopal events, not the other symptoms. Just a word on CLS pacing. This system attempts to have an almost surrogate marker for blood pressure by creating an electrical field between the tip and the can. When the heart is full of blood, there's less resistance to current flow than when it's empty. So it's an indirect measure of how full the ventricle is. And when the blood pressure drops rapidly, the impedance will raise, and then the device knows to pace faster. And this has been shown in neurocardiogenic syncope in double-blind randomized placebo-controlled trials to work 7 times more effectively in preventing syncope than standard pacing. There was a published study called the Spain trial, published in the Journal of the American College of Cardiology, that demonstrated that. We just recently published a series of papers. This is another paper where we looked at, again, a larger group of patients that we've uncovered utilizing implantable loop recorders, and again, gotten the exact same results that if you have people with refractory syncope and they are demonstrated by implantable loop recorder to have recurrent asystole that's associated with their loss of consciousness, utilizing CLS pacing can virtually eliminate these events. Now, at the same time, one of the things that I think needs to be emphasized is we found that patients will be telling us things and no one else has listened. So we've seen groups of patients who say, I have tachycardias and they get really fast, but some of them just come on like really rapidly and then end really rapidly. And sometimes I can even get them when I'm lying down or when I'm seated. And utilizing the loop recorders, I put through this in today. This is a young person who's in their middle 20s who, again, is a classic POTS patient, was having recurrent episodes of syncope with convulsive activity and incontinence. And we just put this loop recorder in a couple of months ago, and this came across yesterday evening. And this was not a bad episode, but it shows you, what's going on out there. So what we've seen using these is some of these people actually have true SVTs with rates of 220 beats a minute. And looking at that, we've said, well, maybe we can fix the part of this, and taken them to the EP lab, identified the fact that they've had AV node reentry, accessory pathway reentry, atrial flutter, a whole variety of things, which we then have been able to successfully ablate. And again, this does not eliminate all their symptoms. It just takes away one aspect of their symptom, but at the same time, it's one that you can eliminate. We've also seen more and more that individuals can display a kind of a tachybrady syndrome. They can alternate between extremely high rates in POTS and then spontaneously have extremely low rates as well. Again, we just published this, again, a case series that we just published demonstrating, again, utilizing implantable monitors that there can be tremendous swings in heart rate. And these are individuals who were not being treated with agents that lowered their rate. So this was not being produced by pharmaceuticals, but rather these are just normally what they were. And then treating these individuals becomes very challenging, just the same way it does in classical sick sinus syndrome. When you go to treat the tachycardias, you can make the bradycardias even worse. So the point is that oftentimes you have to listen very carefully. People can have coexisting pathologies that are going on, and you need to be able to filter out, what's happening. We have found the loop recorders very, very useful in distinguishing whether or not other rhythm problems are going on, because of the fact that they're monitoring constantly, and they're transmitting wirelessly to us. They can't be manipulated by the patient, and they give good objective data. So it's also made me question, even though I've been part of the committees that have established guidelines and all that, that sometimes we have to remember that while we do things for research purposes, reality may be very, very different. Stephen Hopkins once said that the universe is analog, not digital. I enjoy reading stuff on quantum mechanics and things because I find it fascinating about how the universe works differently than our day-to-day perceptions are. And Heisenberg said, since the measuring device has been constructed by the observer, we have to remember that what we observe is not nature itself, but nature exposed to our method of questioning. So I think one of the things that we've been seeing is there can be a group of individuals that live in this realm here. And I borrowed this Venn diagram from the pulmonologist who used it to show the relationship between asthma, bronchitis, and emphysema. And I think that the same interrelationship occurs here, that while there are many people who are purely one thing or purely the other, there are individuals that coexist in this overlap zone that have aspects of both disorders. Currently there is again, I wasn't totally sure who my audience was going to be. There is a very well done double-blind trial done by Dr. Stephen Verino at Dallas Southwestern, utilizing intravenous gamma globulin in patients. We have begun to utilize the same therapy. This is an example, just wanted to show as an ending point. A 32-year-old woman who was spent several months in a hospital in another city near us, had developed POTS, and also was just totally incapacitated. When she would get up, when she would be laying flat, her heart rates were in the 50s and 60s. When she would stand up, her heart rate would literally go up to the 170 to 180s. She began to experience syncopal events. I guess you could say that's partially not classical POTS, but for all intents and purposes. She was worked up. This was a major center. She was transferred. She was tried on a number of therapies, transferred to us. And then we tried other therapies too, and just nothing would make her better. And she ended up being in the hospital months at a time. And so she was completely bedbound, completely disabled, had been running her own business, had 2 children. And all this began after a viral infection. So we administered IVIG. Again, this is just a case study. And very quickly, it's often said that it takes several doses to really see an effect. But let me tell you, very quickly, she began to respond. She was so deconditioned, we had to admit her to our rehab hospital. However, last time I saw her, she walked in the clinic. And so she's been an example of an amazing success to IVIG. We've written case reports looking at the effects of people who get drugs like Humira, who have coexisting conditions. So we haven't given it to anybody but purely POTS, but there have been people who suffer from POTS who also have ankylosing spondylitis, who also have rheumatoid arthritis, and they've received these immunosuppressives, and their hemodynamics have amazingly improved, almost to the point of complete resolution. One of my patients who has multiple sclerosis received immunosuppressive therapy for MS, and her heart rate and blood pressure completely stabilized. So, I think that we're on to something. I think there's a lot of work to do to be able to look at this further, but I think it opens up a whole new possibility of understanding the pathophysiology, and at the same time, not only understanding the pathophysiology, but also providing therapeutic modalities for people who are unresponsive to normal treatments. So, but at the same time, I can tell you that my wife receives Humira therapy, was put on Humira therapy for rheumatoid arthritis, and within 1 year had 5 major infections. So it, you know, so it's can be, you can trade one set of problems for another. There was a part of my life years ago when I was heavily involved in heart transplantation. And one of the major problems that we ran into was not so much people rejecting their heart, but the complications they would have due to the anti-rejection drugs. So I think while this is a very exciting kind of phase, we have to approach it with extreme caution that we don't cause as many problems as we're solving. So thank you for the opportunity to be able to present this to you. I will qualify my statements by saying I'm a real novice to the world of immunology, but I'm trying to learn. And I have the great good fortune to be able to work with a partner who is very easy to work with and understands all the things that I don't. Dr. Gunning has been a valuable research partner, and you know, I'm extremely thankful that we've been able to work together to look at this. So this is just the beginning of a whole new era. And I think this will extend not only to autonomic disorders, but a number of other disorders as well. So it's been an exciting time. Having been in this field for a long time, this is probably the most exciting time of all, because we're finally beginning to understand how these disorders work and have the capability of putting them into remission. I think cure would be a bad word, but putting them in remission. I'd also like to thank the people who don't get thanked much. My first wife, Barbara, who died of brain cancer, is a Hopkins alumnus. She went through the Hopkins pediatrics program and was an attending physician in pediatrics at the Johns Hopkins Hospital, and was the co-director of the East Baltimore Health Plan, the pediatric part of the East Baltimore Health Plan, for years while we were still in Baltimore. And she was, I don't think I would have made it through medical school without her. And after she passed away, I remarried Dr. Eber, who's a PhD in a direct, and now the associate dean at Bowling Green State University. And I have to say, I don't think I could have gotten anything done in life without their help. So I'd like to express my gratitude to both these women. And thank you for letting me share this with you. And I'd be happy to answer anything I can.
Thank you so much, Dr. Really excellent.